Hello, and welcome to another episode of Recovery Matters. This is the show where we talk about recovery from behavioral health issues, mental health issues, and substance use disorder issues. And today we're going to do kind of a controversial subject. We're going to talk about medication-assisted treatment. I don't think it's controversial. In fact, I believe it is a really good harm reduction model now that we are in the middle of the opioid epidemic. But today I have an expert on the subject, and that is Dr. Stephen Loyd. He is on the board of medical examiners now, and he's going to talk a little bit about medication-assisted treatment, a little bit about opiates, and we're going to get going now. Thank you for coming on to the show.
Thanks for having me, Orlando.
So one of the things that I had posted something on LinkedIn about you before I even met you, and it was they called you the opioid czar. Is that right?
It is.
And it was when you were with the Tennessee Mental Health Department, right?
Right.
And they were talking about your addiction, and actually how you've kind of used your experience from addiction to actually help others. So could you tell us a little bit about that?
Oh, sure can. You know, when I see patients, Orlando, one of the first things that I try to connect with is the fact that I've been dope sick. I've withdrawn from opioids. I've withdrawn from benzodiazepines, Xanax, and I know what it's like. I know what it's like to want that more than anything else, including wife, children, job. And so I really think that it changed my career, it changed my life, but it also changed the way that I approach patients. Before addiction, I didn't approach patients that way, and now I use it to connect with them and trying to help them with their own struggles.
So now I saw in the article where you were taking about 100 pills a day. Is that right?
Yeah, you know, and I've been questioned about that before, and the thing is for the longest time I didn't count because I didn't want to know. And I know how many, obviously after I got, really deep into my addiction, because one thing I was sure of every day is, do I have enough pills to get through the day? And anybody who's been addicted will tell you that they do as well. And so I got a prescription one day for 90 oxycodone, and I used all of them that day before I went to bed, and I actually needed more before I went to bed. And so at that point I knew where my levels were, and at the end, the worst I ever got was to about 100 to 105 5-milligram Vicodin a day.
So now when you went through your addiction, we were talking a little bit, you went through a treatment center, correct? And they did back then just kind of like a 3-day detox with Suboxone.
They did. Well, Suboxone had been approved through the Data 2000 Act in 2001.
Okay.
And so it wasn't widely used back then. I got into recovery, got help in 2004. And so I came here to Nashville. I grew up and was born and raised and worked in Northeast Tennessee, a little town called Jonesboro is where I'm from, but I was working in the Tri-Cities. And so I came to Nashville and went to Vanderbilt for detox. And at the time they were using injectable buprenorphine, which is called Buprenex. And so I got 9 injections in my left arm over 3 days. And that was it.
Okay.
And it did help. What helped more than anything were the wonderful people at Vanderbilt that took care of me, who I'll never forget, and have actually run into in circles now that I live in Middle Tennessee, 15 years later. But it helped with the symptoms, but withdrawals were still extremely difficult. And the benzodiazepine withdrawals, Xanax, were devastating. I still have, flashbacks to that one every now and then.
So aren't they extremely like hazardous to take together, like benzos?
Oh yeah, sure. Like, you'd think I'd know that, right? And I did. I did. And that's the thing that I try to tell people about addiction. I was aware of that. I was aware of the toxic doses of Tylenol I was taking. I got a great story about that for you, so I want to make sure we get to that. But I was aware of that, and I knew that those two drugs together were lethal.
Right.
But I did it every single day, and so it didn't hurt me the day before, so it's not going to hurt me today, and likely won't hurt me tomorrow. At least that's the story I told myself.
Right.
And I was educated. It wasn't like, I was early in my medical training. I never used a pain pill until I was in my chief resident year, which is 4 years of medical school and then nearly 3 years of residency. Okay. So I was within months of going out on my own. And so, but it didn't matter. And I told you I had a good story about about knowing it'll hurt me. But you think about taking 100 pills a day. Well, oxycodone in the form of Percocet or some of the other combinations, Vicodin, hydrocodone, and acetaminophen, they all have Tylenol in them.
Okay.
Tylenol is extremely toxic to your liver, and so I knew what kind of danger I was putting myself in, because I had taken care of patients who had overdosed on Tylenol numerous times in the hospital. And so I knew what the anecdote was for Tylenol. It's something called N-acetylcysteine. And so when somebody overdoses, you put an NG tube down in their stomach, and you pour N-acetylcysteine down to neutralize the Tylenol. So I knew that's what we did, but I couldn't take that out of the ER. So I went to the health food store and bought bottles of Liver Health, which is really N-acetylcysteine. And so I would kind of look at the bottle, and if I took this many Lortab or Percocet, I just kind of took this many N-acetylcysteine thinking it would protect my liver.
Really?
Absolutely. And I love talking about that, because think of the mindset.
So
right?
that's an addicted brain right there.
No doubt, no doubt. And I actually had a pharmaceutical company that heard that story, because I told it on something else I did at some point. And a pharmaceutical company actually called me up and asked me about that, because they had no data of anybody ever doing anything like that. And it was purely anecdotal, purely my own experience. But that, I think that gives people a little bit of insight into the mindset of somebody who's addicted.
Yeah.
Now, I know you understand.
Oh yeah, no, I actually, I definitely understand. So for you, those of you who don't know, I'm actually celebrating 10 years in January, as he knows that I also struggle with substance use disorder. And so, but just to go back to the Tylenol thing, how much is toxic for Tylenol? That's not something I really know.
Around 3 grams was, when I was in residency training, that's what we would look at. So if you have, 325 milligrams to 650 milligrams, depending on what preparation you're taking, you could see really quickly. I mean, 3 grams is only 3,000 milligrams.
Right.
And I'm not sure what the toxic levels are defined as today. I'd say they're, still pretty close to that. Always cheated and looked it up. But I knew I was taking more than that every day.
Right.
And I would actually go into the lab at the hospital, because I knew people who drew the labs, and I'd say, would you mind pulling some liver enzymes on me just off the record, so I could check my own liver enzymes?
So they never asked any questions about any of this, like when you get people to write you prescriptions or checking labs, just to.
No, they never did. And one of the things is that, when I was using, and even now, I've never been a yeller. I mean, I don't throw scalpels or things like that, and so. People just didn't see it in me, and I'm sure they thought it was a little off base, but it was, it was Steve. He was, he knows what he's doing. Which the truth is, I didn't.
Right.
But they really were trying to help me, and so most things, Orlando, in my addiction, I would not take back, because they made me who I am today.
Right.
Those things where I took advantage of other people's goodwill towards me, I would like to take those back.
Okay.
Because they really tried to help me, and of course they didn't say anything. And no record of those labs exist. And my doctor buddies that I hit up for scripts, they really thought they were trying to help me. It's one of the things I try to tell young physicians in training now. If you have somebody that asks you for a prescription to control substance in the hospital, first of all, don't write it, because you're actually breaking the guidelines by the Board of Medical Examiners in the Drug Enforcement Agency of the United States. But more importantly, they're asking you for a reason. Right? Why are they not going to their own physician? And so that may be a time that you could see if they need help. And the sad thing is for me that most of the people that I was getting scripts from would have absolutely helped me.
Okay.
They would have absolutely helped me. But it's kind of like the person who's struggling with alcohol use disorder. If they don't want anybody to know, they don't go to the same liquor store every day, right? And so I didn't hit them up. I would actually had a little chart when the last time I called them, to make sure that I didn't do it too close together. And because I didn't want them to know, because I was scared that I would lose everything I'd worked so hard for.
So why do you think now that, because I know that when you got detoxed, it was just detoxed and it's done. Why do you think it's so necessary now for people to really look at medication-assisted treatment as a solution to what's going on with the opioid epidemic? Well,
I think you have to look at, because of my profession, the treatment that I had access to and the treatment that most people have access to. So I had access, because the truth is, Orlando, I cost too much to throw away. I mean, if you're a tax-paying citizen in the state of Tennessee, you paid for my medical education, and I thank you. Right? I paid tuition, but 3/4 of it's your tax dollars.
Right.
And so it costs a lot of money to make me. So rather than kick me to the curbside, and we have a shortage of physicians in our state anyway, it'd be much better to rehabilitate me and put me back into the job that you sunk all this money into, right? I mean, it makes sense. I would argue that it makes sense for everybody, right? But that's the way physicians, were looked at. So I had access to 90 days of high quality inpatient treatment at one of the best places in the United States. I had 5 years of aftercare and follow-up provided by the Tennessee Medical Foundation that not only held me accountable, but helped me take better care of myself, involved me in a recovery community, and you know how important that is. And so at the end of 5 years, I mean, I was pretty well grounded, and I didn't really want to change anything, so I just kept doing all those same things, and I do them now, over 15 years later. Most people don't have access to that because insurance companies and insurances, they do pay for treatment, but they don't pay for that. I mean, if you look at the cost of that today, it's going to be $25,000 to $33,000, $35,000 a month for 3 months.
Yeah.
So you're in the area of 90 to 100 grand just for the treatment.
Right.
Now 3 months out of your life, 3 months away from your job. And Orlando, I really was so fortunate in the people I had helping me. The president of my university back in East Tennessee at East Tennessee State was Dr. Paul Stanton, and he paid me the whole time I was gone.
Oh, wow.
He had an understanding of addiction. My dean of my med school where I was employed was actually a psychiatrist, and so he had an understanding of addiction and liked my work before, my addiction got so bad. And they felt like I was worth a chance. And his name was Ron Frank, so I want to mention his name. And I love him. And they gave me that chance. I never missed a paycheck. Okay. How many people do you know get to go to treatment for 3 months with 5 years of aftercare and follow-up and get to keep their job the whole time with full benefits?
Well, that's amazing.
Almost none. And so if you look at it, probably doctors, attorneys, judges, celebrities, sports stars, maybe, outside of that. Wrestlers, professional wrestlers, believe it or not, but some limited folks in the airline industry, but for the most part that doesn't exist. And so I got really interested in medication mainly from watching my patients struggle, and then as the opioid epidemic progressed, watching them die. Because they would get approved for inpatient treatment of 7, 14, 20 days, and then step down, which is the model that's used, and they just didn't get long enough in treatment for the frontal lobe of their brain to recover, and they had almost no chance, went back out, relapsed, and died.
Okay.
And
so when we're talking about an opiate addict or someone who's struggling with opioid use disorder, how long does it take for the frontal lobe to repair itself?
This is the best part of my talk, and I know you've seen it multiple times, but it's my most impactful slide because I'm not a big slide guy, right? I've got a bunch of pictures, but that slide in particular looks at PET scans of the brain, and for the frontal lobe to start to come back online takes 90 to 100 days. Okay. So, and that's just to start to come back online. Fully back online and complete abstinence, it takes 2 years. So I see people that say, well, they're doing well on medication, they've been on it for 6 months, isn't it time that they come off? And I'm always cringe because I know what their frontal lobe, I know where it is. The scans tell me where it is. And the frontal lobe of your brain is only important if you care about insight, judgment, and empathy. If you don't care about those three things, then it don't matter. And I always want people to know, how would you do in your day? How would you do today, 10 years in recovery, if I took away your insight and judgment?
Not so well,
no,
obviously.
No. You would be.
I don't think I'd be doing this.
No, of course not. You would be here. You would be totally at the will of your reward system, your limbic system, totally pleasure based, and just let your mind go where it wants to there, and so that's
I
really.
was a meth person, so I'm very aware.
No doubt. But that's really what people are struggling with, and most people don't understand the phenomenon of cravings. And we talk about cravings, it's always easy to relate because everybody understands being hungry. Well, think of your cravings for food, and then think of somebody who was struggling with substance use disorder secondary to opioids. Their craving for their drug are 10 times stronger neurochemically than your cravings are for food when you're hungry. And so when I get folks that say, Steve, these people just need to stop. They just need to put it down. I'm like, yes, golly, you're so right. And I would like for you to stop eating. and I don't mean today, right? I mean going forward, because that's what we're asking people to do. It's not impossible when you give people tools, you help them change their behavior, and more importantly, start to deal with some of the trauma issues that most people with substance use disorder suffer from.
So I think that's the argument, is that a lot of people are thinking that they're just substituting one drug for another, right?
Yeah.
And what do you say to people that think that they're just trading in one drug for another?
My knee jerk is, if I agreed with you, so what? Now that's not the answer I want to give you, but so what? I have something that I can give them that's going to take them out of the behaviors that they're in right now, of where they have to seek a pill or a needle every day, young women prostituting themselves, young men prostituting themselves, not able to hold a job. I have something that I can give them, and that effect is going to happen almost immediately. So my question to you is, so what? Because when we treat diabetes, we don't treat diabetes because the blood sugar is high. Who cares? We treat diabetes so that the sequela from the diabetes doesn't happen. You don't lose your foot because of vascular disease. You don't lose your kidneys. You don't lose, the vessels in your neck and have a stroke, right? Because of vascular disease. So really, we treat blood sugar to prevent the sequela of the disease. Orlando's the same thing. I'm treating that to prevent the sequela. Only the sequela here, unfortunately now, is all too often death because of illicit heroin, and a lot of times it's been adulterated with fentanyl, unbeknownst to the person using it.
Right. So now, when you're talking about the frontal lobe and it repairing, so have you looked at brain scans of people that have been on medically assisted treatment for, 2 years or 3 years? Is it repairing itself, or are they staying at the same place?
Right. So that's a great question. I get that a lot of times, and hopefully this spring we'll know the answer to that. The research that I use with the brain scans that you've seen and that are in my talks is from Nora Vokow, who is the head of NIDA, the National Institute of Drug Abuse, and one of my heroes. And she actually did that work in 1992 and 1993. So we've known this for a while, right? This is not earth-shattering stuff. Right now, those are the studies that are happening. And so when I show scans, these aren't Steve Loyd scans that he did on his patients. I'm using published, peer-reviewed data because, Orlando, you can't do anything without data.
Right.
I want to know what works. I want to have a reason for why it works. And I want to be able to explain to people why I'm doing what I'm doing. And I can do that. We don't have that data yet, but hopefully by the spring we will.
What does it look like, or just what do you think you're going to see?
Yeah, there you go. Thank you. I appreciate that question.
What do you think?
Well, if you look at it, I think with methadone, which a lot of people do really well on methadone, and I think it is a needed tool in our arsenal. It's a full opioid, and so I think that the recovery rates of the frontal lobe you're going to see are going to be similar to other opioids.
Okay.
Buprenorphine, which is the active drug in Suboxone, it is a partial agonist. And so I think that recovery, theoretically, it makes sense for me that recovery will happen quicker. Now, Trexone, which is not an opioid, is a blocker. I think brain recovery will happen exactly as it did in the people with abstinence.
Okay.
That's what I think going in, and I'm sure that's the working hypothesis.
So you just talked about the three medications, so methadone, Suboxone, naltrexone. Of those three, what do you think in your practice is the most effective that you've seen, or that people have been most successful with?
The one that's right for the person sitting in front of me.
Okay, so there's not one that you would choose.
There's not one I would choose.
Okay.
My mission statement that I live by is that when I get up in the morning, I want to help as many people find the path to recovery that's right for them as possible. And when I get calls, when you call me to do this, right, I put it to the test, right? Is this going to help me in my mission today? And the answer to that's yes, which is why I'm here.
Yes, thank you. I'm hoping.
And I love you, right?
So.
But no, both of those things. But this will help people. There'll be people who watch this that make a connection, that are struggling, and maybe try this route that they have been hesitant to try before because of stigma. So my goal is to help people find the path that's right for them. There are a lot of people who do really well on naltrexone, which are injectable Vivitrol. There are folks here in Nashville that are doing great today on methadone. And then, of course, the bulk of my experiences with Suboxone, buprenorphine type drugs, but I would never tell anyone the route that they need to go. And it's interesting, I get people all the time say, well, you can't let patients choose, and I always laugh at that. Patients choose anyway.
Yeah.
And I don't care if we're talking about hypertension, I don't care if we're talking about diabetes, or we're talking about urinary tract infections. Patients choose anyway. We make suggestions in our training as physicians, but the truth of the matter is patients do what they think's best. And so what my job is to help the patient find the path that's right for them. The biggest hurdle to that is addressing stigma. And I've had this scenario happen more times than I can even count, and it breaks my heart every time. But I get a patient that I know is at high risk of overdose. And how do I know that? Because they've got multiple overdoses in the past. They've been reversed with Narcan multiple times. And I know that they're going to get 20 days, 25 days of treatment maybe. So I know where their frontal lobe is. They're going to go right back out in the world with those same cues, those same cravings. I go to them and I say, look, here's your best shot. And I lay it out. And for some of them, I had one young lady recently, it was methadone because she had struggled with everything else. And her parents said, oh, you're switching one drug for another and you're not going to be allowed back in the house to do that. And then say, okay, and then, you know, they're right and I'm not going to do that and I really want to try this. And then they overdose and die. And that is not an uncommon scenario. And it's one that breaks my heart.
So with methadone, just since we're on the subject, do you find that, so what I'm seeing in the treatment industry is that when people get on methadone, they tend to end up at really high doses, like 120 milligrams, 100 milligrams, and nowhere is detoxing that really right now. So what happens when those people want to get off? Like, how does that work when you have this kind of imbalance in the industry that you're putting them on, but you're not able to get them off?
So can we address the dosing? Because I think it's really important. So if you think about it, and I'll use me as an example. When I started taking the hydrocodone, I took 2.5 milligrams the first day, and it gave me all I wanted. Right? 3 years later, I got to take 500 milligrams, not to get that effect, but just not to be sick. Right? So what happens over time when you're taking an opioid from the outside, your body makes more opioid receptors, right? Because you get more and more and it makes more and more, and so now you got to fill all of them up. We got to remember that the pleasurable effect is a combination of neurochemicals, but mainly dopamine. So the opioid receptor stimulates release of dopamine. So those receptors have to be occupied in order to stimulate the release, but then the whole time the receptors for dopamine with all this exposure are actually going down in number. So you need more and more for less and less effect. And anybody who's ever been addicted to opioids will tell you that, right? And so whenever you're dosing methadone, you want to occupy all of those receptors. So you adjust your dose over time slowly because methadone stacks, right? And so you adjust your dose over time to occupy those receptors. How do you know when those receptors are occupied? Their drug screen's negative for other opioids.
Okay.
Right? So you're drug screening consistently, and as long as it's positive for other opioids and they're struggling with cravings, then you go up on the dose until that drug screen's negative. Now, you're right, sometimes that'll take 120 milligrams. If Stephen Loyd had walked into a methadone clinic back in 2004, I am positive that I would have been on more than 100 milligrams of methadone. I was taking 500 milligrams of oxys a day. It is harder to detox people on those high dosages, but there are people who do it. And so we will take patients on higher doses of methadone. It just takes longer over time, and there's a kind of an art of switching them over to buprenorphine, and that needs to be done medically supervised if somebody has experience.
Okay. So, so we're talking a little bit more about, what do you say to people that say Big Pharma created the problem and now they're trying to create the solution? Is there any relevance or validity to that?
Absolutely, there is.
Okay.
I think there is. And in Orlando, I have to do what keeps my patients alive. And sometimes I have to do it while holding my nose because I am not a fan of Big Pharma at all. But this is a drug that we know that works and we know that it will save lives. It has about a 50% mortality benefit. And so for the time being, it's the best thing that we have, even if it is from Big Pharma.
Okay. So I really appreciate you coming on and being so candid about all of this. Would you say that in the next, do you think with the use of medication-assisted treatment that we're going to see a drop in the overdose deaths? Is that something if we embrace it a little bit more?
Absolutely. The states that have Medicaid expansion and have increased access to evidence-based medicine have seen drops in their overdose death rates.
So could you kind of explain the three medications, which would be methadone, Suboxone, and naltrexone?
Right. So the three that you named are all three anti-craving medications, which is how they work. By different mechanisms, they prevent cravings. Cravings are why people relapse. If we can keep cravings at bay and hold people in behavioral health until they can achieve behavioral change and give their frontal lobes time to wake up, address childhood trauma, we give them a much better shot at recovery.
Okay. So do you find that trauma has a lot to do with opioid addiction?
Yes, a whole lot. Adverse childhood experiences are paramount and absolutely need to be addressed in the treatment of people with opioid use disorder or any substance use disorder.
Okay. And so with that trauma, do you find that inpatient stabilization or medication-assisted treatment, is that better for people? Does that seem to be a stronger possibility if you do an inpatient Suboxone program where they stay on rather than taper off?
The advantage I think it gives you is it takes people out of their environment. right? And so as long as I'm out in my environment, I'm not having to look at me. I'm not having to work on me. I can focus on other things. So I think the big advantage to inpatient is that. Can it be achieved outpatient? Absolutely. It for sure can.
So what do you think the better success of starting someone on Suboxone? Is it, have you seen it work to where they come straight off, they detox and go on Suboxone? Or is it usually they need to kind of be in a stabilization space for 7 to 28 days?
I'll give you the answer I gave you a minute ago. It depends on the patient. But most patients that I have come to me acutely dope sick. And so I start the Suboxone on that day. Others, I have to wait till they get dope sick until I can start it. Methadone, you usually don't have that issue as bad because it doesn't precipitate withdrawals like buprenorphine can. Now, Trexone, they have to be off of everything for 7 days at least, because you're worried about throwing them into withdrawal in case they still have opioids in their system.
Right, and people know that as Vivitrol, right?
Absolutely, Vivitrol.
That's the name brand now?
That's it. I try to stay away from those, but let's talk what people know.
Right, just in case people were confused a little bit. Well, thank you so much for coming on and talking to me. This has been Stephen Loyd with the Medical Examiner's Office, who is actually talking about medication-assisted treatment, which is the new recovery method. Thank you very much for joining us, and until next time.
We are currently undergoing a mental health crisis. Millions of people are struggling with depression, anxiety, PTSD, suicidal ideations, or a substance use disorder. If you or someone you know needs help with a behavioral health, mental health, or addiction issue, please reach out. There is support for what you're going through. Call 800-676-0929 to speak with a recovery navigator who will help you find support. Again, call 800-676-0929. Call now. Recovery is possible, and recovery matters.